Hi, everyone. Welcome back. It's Dr. Steve Rasner, and you're tuned in to the Lionhearted Dental Podcast. Welcome. Hey, listen, first, I can't help it. I got to thank everybody that downloads me and your new friends that download me, that maybe you turned them on to the podcast because it's going a little bonkers in a good way. And, it wasn't that long ago. I remember, I think it was November, December, I was trending the other way. And I deserve to trend the other way because I wasn't putting my heart and soul in something that I do. And it works the same, by the way, for your dental practice. So thank you to everybody that downloads me. And it seems like it's every country that it used to and more. It means a lot. I got a good one for you tonight. I've thought about it like I've been doing a lot lately. And I'm going to title this one tonight, The 5 Minutes That Affect Everything. And I've talked about this many times in different ways on other podcasts. And the reason I'm bringing it up tonight is because there's nothing better and more I could talk about with you that would help you have an impact on whatever you're doing in dentistry right now. And let me elaborate on that. If you're an associate, you're getting paid a percentage. So if you produce more, you'll make more, right? If you opened up your own practice, of course this applies to you. So the 5 minutes that I'm talking about, I want you to really don't be doing other things right this minute while you're listening to this particular podcast. Don't have me in the background and don't be not concentrating. I know that's not proper English. I'm doing this after work. I don't really care. Okay? You need to hear what I'm saying because what I am saying is so dead on true. So the 5 minutes I'm talking about are those first 5 minutes that you walk into the operatory with a new patient and what should come out of your mouth and what the consequences are for that. I know we've beat this and covered this in many different ways before, but just think about it for a minute. Think about if everybody that you looked at what their data is, you've looked at their x-rays and their medical health history and charted everything, and then you listen to their concerns. What if everybody said yes? Do you think about the impact that would have on how you operate each day? It would be amazing. I want to tell you something. It happens to me. You know what happens? It happens when I'm giving those courses live that I give. Do you know why? Because money's not an issue. We don't charge the patients to extract their teeth, to graft their teeth, to place implants on their teeth. That service is provided at no charge. So when a patient comes in that I'm screening for my live courses, of course the answer is always yes. The money is not part of the equation. Well, you can't do that in private practice, but I can get you really, really close. And I've thought about this. I call it the 5 minutes because even though the new patient visit and a new patient experience is way more than 5 minutes, and obviously, and I've said this before, the new patient experience starts with your branding. It starts way before that patient ever gets to your office. Do you know that when patients come into my office, new patients, and I don't mean this in any way to be arrogant, I swear I don't. I mean it because I'm trying to share with you the impact that your branding can have. It is whatever I put out there over these years and the way that I've put it out there. If anybody want my ads, write to me for God's sakes. I know this isn't my own opinion, it's the opinion of my staff. The attitude of this patient that comes into my practice that's new is like, we are celebrity dentist. We are a celebrity dental office. And they feel fortunate that they have an opportunity to join our patient family. Now, if that came off wrong, I don't mean it to. It really, that resonates over and over again each week and each month that I'm in practice. And so, sure, yes starts with your branding, and I've explained it too many times, and it carries over to when they make that first phone call, and who are they speaking to? See, when I said focus tonight, are you doing those things? Do you brand properly? I know if you're an associate, you're not branding at all yet. Your office, whoever owns the office, is doing that branding. But eventually, you'll be in a position to do that. You know, there's many podcasts I've done on branding and marketing and what you should be putting out there about trust and confidence. But at some point, you are going to meet this patient who hasn't found you yet. And those first 5 minutes are everything. And so many times when I'm in that moment, which I love, by the way, I think of you. I think of you and I think of, am I explaining how important this is right now to my audience that faithfully gives up a half an hour each week to listen to me to get better? I know one thing. I have never, ever been close to this good at this particular aspect of what we do each week. Meeting a new patient and bringing them in 5 to 10 minutes. So this is how we do it. And this is something you should go back. I want to tell you before I do this, and listen again. Are you doing this? If you're not getting enough case acceptance, do you have something similar? I would hope that you would practice what I'm about to say to you on your computer and look at yourself and edit it if you want, or copy it exactly. I would prefer, until you're smooth with it, until it just flows. So I walk in, and remember, part of this yes, part of a patient saying yes to case acceptance is you being on time and not making them distracted and angry because you don't realize the importance of timing and the smoothness of the whole flow of this new patient experience leading to them accepting treatment. And one way to kill that vibe is let them sit out in your waiting room when their time is at 3. Let them sit there until 3:25 till somebody comes and gets them to take them back. Don't do that. So I walk in, all this has been done the way I want it to be done. And I sit down and say, hi, I'm Doc. Sometimes I say I'm Doc or Dr. Rasner. And I'm 70% of the time I'm looking at a patient in my chair. And there's a series of chairs I bought that are portable, that are comfy with wheels, that the significant other is sitting in. If you're tuning in to me for the first time, yes, I bring the significant other to this very first visit if I can. And that is not pie in the sky. If it doesn't happen to you, you just haven't asked for that to happen. So first thing I say is, so tell me, where did you find me? And I do that on purpose for what I call common bonds. So imagine you doing that. When I do that, most of the time, they say, well, you're everywhere. Because I do market fairly heavy. And you have to do that when you put a Starbucks in the desert, and that is the arena that I'm in. You understand when I share those numbers with you of what we were able to accomplish in dentistry in my offices. I'm doing this in an area where everybody else they can go to, this is a fact, takes insurance, and even though and on top of taking insurance, their fees are less than mine. That's on them. It's not on me. And it's not because we earned our fees. We spent a lifetime putting together clinical skills through a dedication to CE and people skills through leadership that finds it important to combine both of those. And now I'm unabashed about our fees. So when you're able to do that on a consistent basis for 40 years, it's not luck. Okay, so a lot of times, once in a blue moon, somebody will say to me, when I used to, they don't say it anymore. I saw you on our insurance list. I mean, that's a buzzkill for sure. So this is the beginning of the 5 minutes I want you to hear. I say this. I said, well, listen, what I do with my new patients, I like to tell them who we are before I even start, because I know that it's going to be different for you, and I know you're going to like it. And I say it just like that, and it feels not weird at all. Then I say this often. I say, tell me, what is it you do, or what did you do in your career? And today somebody answered me, they were a teacher. Okay? Whatever they say, I can play off of it. So I said, you know what? Whether you're a teacher, a lawyer, cop, or a dentist, we're not all in at the same level, right? I mean, you can have a job and like your job, but you don't have to love it. It doesn't have to be the center of your universe. And, a lot of people are okay with what they do, including dentists. I said, the problem, though, in our profession of dentistry is that it's really, really hard. It's hard to put it all together and work in a small space. I say this to these patients. And it's easy for burnout. And the problem in dentistry is that if you fall out of love with it, it's very unlikely you're just going to run from the profession, because it takes so much of a time and financial investment. I'm saying this to these patients, to be in it. And when you pick up the phone to call a dentist, you don't have any idea who you're calling most of the time. Despite whatever marketing or advertising they use, you could go to somebody half in. And when you're half in, I don't think you always make good decisions. Now, that may seem harsh, what I just said to you. Maybe some of you think I'm Benedict Arnold right now to my colleagues. I don't feel that way at all. I feel I'm absolutely just stating a fact. I feel I'm telling just the truth. There are just too many of my colleagues that are in that situation. They're in your community. And here's the beautiful part. It's okay. But there's no way that describes a Lionhearted podcast listener. Why would you be listening to try to get better? And I'm sure I'm one of many podcasts you listen to. And I'm sure you take a plethora of C education. I've met enough Lionhearted listeners to know they are listening to me because they are Lionhearted. Lionhearted means you don't give in. You don't give in and have a career and accept toxic insurance. You don't give in to just being mediocre. You take CE to be better. I already know what a lot of your practices are like. If you're truly on board with the principles that we discuss here each week. And so the beautiful thing for us is it's not beautiful for the entire profession. Listen, it does happen in every industry. You think all physicians are all in? All lawyers are all in? It's pretty naive. They're not. So when somebody's in front of me, I think an easy way to distinguish myself, Look at the work that you guys come across each week. Are you kidding me? It is the evidence of what I just said to be true. We all see it. We all see crowns. I can tell you one thing. I'm no Bill Strupp, I'm sure, or Frank Spear or John Coyes. But we're pretty damn good, and we're pretty proud. And many of you are exactly like I am or better. I can tell a full coverage restoration of mine the second I sit down without even putting on my loops. They just look different than the masses of full coverage crowns of other patients that come across our office. Or the worse than that is this. The lack of thought in a patient's oral health care that did go to the dentist every 6 months for the great majority of their career. So what do these patients often have? These patients often have multiple missing teeth, crowns and a maloccluded dentition, very average to below. I mean, don't you love it when you look in the mouth and you see, I do, beautiful direct restorations? It tells me what kind of dentist that dentist was, but I don't see it that often. Okay? And so I have to tell you that I think what I just said is a fact. So I'm getting off the track. I say to them, not everybody's all in. I also say nobody wakes up in the morning in my profession and says, oh, I'm going to just do a mediocre job today. But if you're half in to what you're doing, that often is the outcome of the clinical care. Before I get to the next part, I almost feel bad saying this tonight, even though I know it to be true. But that is what I say. And then I say, but that's not me, because I don't know how it started or why I felt exactly the way I felt. But from the time I became a dentist, to me, I was all in. It was everything I thought it was and more. And I did everything in my life to further being better at the thing I love so much. And I say it just like I'm talking to you right now. And I want you, if this is true for you, to go back and do it in your computer record it and see if it seems sincere and real. And at that moment, it's not even 5 minutes. It's a couple minutes, I say. And then I go on and I say, so I spent a lifetime taking CA. And it didn't seem laborious to me. It didn't seem like I was sacrificing. Because a lot of times the patient at that point, if you talk like this, will say, that's because you're dedicated. And I will often sometimes interfere and say, I may be dedicated, but I love it. It doesn't seem like a sacrifice to take weekends off and become better at this. It doesn't. Never did. Do you get me right now, guys? Do you talk like this? This is somebody I just met. So the next thing I say is that probably the best thing that I ever learned in these CE courses was something that I call what to do when. I say, and they get that. I say, what that means is when a new person comes in, like you're in here today, how do you know the right thing to recommend if you're me? We want to do that. We want to recommend things that'll make you happy when we're complete and done. And we want to be responsible. And no, in my opinion, and there's another truism, guys, I think there's two scales of dentists. There is a dentist, often it's over-aggressive. And perhaps they take approaches that a lot of dentists would not do, whether it's crowning a tooth that maybe could be filled directly, or whether it's whatever it is, there's a sense in these practices that maybe the patient has been overtreated. And I don't think there's that many of those. And I say that. I think what's worse by far is good old Dr. Joe, whom I've talked about endlessly on this program. And Joe might be the guy that's half in, because Joe never wants to do anything. And you guys love him because you spend less time in his chair and it doesn't cost you any out-of-pocket money. So it feels good to the patient. The problem is when Joe retires or you're forced to have to go to a different dentist, there is a ton of real work that you need. And the reason that happens, folks, I don't say folks, the reason that happens is because I chose a profession where a lot of what's wrong with patients' mouths, doesn't hurt. Gum disease doesn't really hurt. And by the time it does, it's too late. A cavity. Sometimes I'll look at a patient when I'm doing this. Now look, I can do this like this, and I can be very fluid and break up and change. I always start the way I just told you. And there's little variations of that, and there'll be variations for you when you do it. But sometimes, remember, their x-rays are already in front of me. And I may see a large cavity, or I'll see a tooth that clearly needs a root canal. There'll be a periapical lesion. I'll say, for example, so I'll stop what I am doing. I said, for example, which I know I'm going to go back to this. That tooth on the lower left, do you have any pain down? I'll ask them, do you have any pain? And they may say, on the upper left or whatever. Very often, I can verify and affirm to them what I'm saying is true by pointing pathology to them that may not even hurt. And I'll say, so why doesn't that hurt? It's because that's the science of dentistry. A lot of what we diagnose doesn't hurt the patient. And so that's why the onus for me to do a comprehensive exam on you is responsible. You know, if I was a dermatologist, do you need me to tell you that you have a big rash on your face? Or if you have a temperature, you don't feel good, do you need your primary care physician to tell you and convince you something's wrong? That is not what happens for us. The raging toothaches, the blowing up of the face just doesn't come across that much. And of course, those patients need treatment. So I just want to continue. Wow, this is going to have to be a two-part thing with you this week, but I want to continue to the next. So then I say this. I say, the course that impacted me the most in my career, or the thing I learned, was what to do when. And you're here today, and the way that I do that, Mrs. Smith, or whatever I'm calling them, and I always defer to be formal and let them correct me. Unless it was obvious in the first minute or two that this guy is okay to call Joe or whatever. You get me? So I said, the way I do this is I want you to look in this box right here. And I'm going to take a tour through your mouth. I haven't looked in their mouth, folks. I'm going to take a tour from right to left, and then on your lower left over to your lower right. And together, I'm going to candidly just take a cursory look at you and tell you what I'm seeing. Upper right to left and then down. I've never, guys, ever, during what I've said to you, had somebody interrupt me, a patient, say, I don't want to, can't you just take an x-ray of my tooth? And because we screen these patients, literally as I'm looking you in the eye right now, I have never had anybody stop me. All I have ever heard or felt was an incredible closer bond with this patient trusting me, of which they should. I'll often say, by the way, I had a patient in today. Just want to tell you real quick. I had a patient in today, 70 some years old. Her mouth was a complete train wreck. And it was shocking because she did not look that. She dressed pretty well. It's funny because I looked at her and I said, you just look like somebody that would own a bookstore. And I didn't look up what she did. I usually do. And she owned a bookstore in a very nice area, not near me, out of the area. And she had heard of us, and patients came to us that she knew. All that came up because I asked her how she heard of us. And her mouth was blown up. She had multiple teeth, by the way. It wasn't like she came to me. She didn't have periodontal disease. She had decayed teeth, which is shocking to me. So I want to tell you, as I said, I often deviate, and I want to know that because this was going to be a giant treatment plan. So understand, and I am going to make this 2 parts because the hardest thing for me, I've coached other dentists off and on for 24 years, besides being a speaker. I privately have coached clinicians and even charged them, which I haven't done in years. And I don't know why I didn't keep, I was very successful. I don't know. I want you guys to succeed without having to pay me any more than you have to. I mean, you don't have to pay for the podcast. So, and one thing I learned when I was coaching is I could teach the dentist a lot of things pretty easily. But teaching my colleague how to figure out what to recommend at that visit is probably the hardest thing I ever came across because so much goes into this. And with this woman in my chair today, I want to tell you my thoughts. Her physical appearance did not match what was in her mouth. I'm serious. And so why is that an issue? Because she spoke of somebody who had means, who had the ability. Often in my geographic area, and I've taught my colleagues for years to never assume what your patient's going to need by looking at them. I had a guy come to me once. I'm going to go back to this woman. I'll probably stop here, but I want you to hear these 2 stories. I'll never forget him. He's still a patient. He came to me 25 years ago. And, he was tattooed up 25 years ago. He just didn't look like he had anything. I couldn't help it. And his mouth was blown up. And I looked at him, and I was in that process that I'm trying to teach you tonight and next week as well. How do you figure out what to recommend? And sometimes you catch a break, or maybe you do. And as I'm looking at him and becoming very clear very quick that if he wants to keep his teeth and he wants fixed restorations, then this is going to be huge. So what I do, if I don't know that, like I'm looking at the x-rays, I did the little talk I just did, and now I'm looking at his mouth and I'm starting my exam, and it's crystal clear that he has to make some decisions to help me recommend. Because sometimes what you do in that case is you sit the patient up and say, listen, I want to talk to you. When I get to a patient like you and I've only looked for a few minutes and I kind of see what I'm seeing, I need more information. And the information I need from you is where do you want to go? You know you have multiple teeth that need work, right? They know that. I said, well, there's a very big difference to me and to you in terms of time, cost, everything, as to which way you go. I mean, obviously, a denture is much less of an investment than fixed bridge work or implants. You know what he said to me? I'm not kidding. I remember it word for word. He said, there's no price you can give me that'll be too much. That's what he said. The tattooed looked like not a guy that would say that. And his case was $80-some thousand, and he wrote a check. It's absolutely true. With this woman today, I should have said that. And I was in the process. I sat her back up because I knew now that I have to make some decisions. Where are we going? Are we going fixed? Are we going removable? And so there becomes a lot of avenues once you get your wrap down that you'll stop and you'll deviate from something you may have done 10 times in a row because you need to. You get me? And with her, she certainly didn't have, it was either going to be an upper denture or it was going to be a lot of implants. And there's a very big difference in that cost. But even the denture was going to cost a lot. And this particular patient had to treat upper and lower arches, which isn't always the case, but often is. So a question stopped to me, which made me sit her up in the chair. And that question was, I need to ask you a question. How long have you been like this? And why? Because it just doesn't fit with you. And you see my face? I don't think that's insulting. It's sincere. Because I wanted an answer. If she told me, she goes, it's pretty recent. I let myself go. I forget the reason she told me. COVID and other things. Things started coming apart. Lots of times there are legitimate reasons. They take care of an elderly parent or a handicapped child, and money was tight all those years, and now they have time. So you need to know, because maybe they do want fixed, etc. As it turned out, and now I want you to also know I have models to my left, which you've heard me talk about. And one thing I said to this patient was this. I said, I want to tell you something. As I might have said exactly what I'm about to tell you, but I don't always say it this way. I said, as messed up as your teeth might be, when you go to eat food right now, this is a denture, Mrs. Smith, and I hand her a denture that's on a model. And I said, when you go to eat right now, even with the decayed teeth you have and broken down, you can actually chew and rip food better with those teeth than you will be able to with most dentures. And that's true. I said, that said, a lot of people adapt and learn to do quite well with an upper denture. In my opinion, never on the lower. And so she had a couple teeth on the lower. And I said that to her. I said, this is a lower denture. And I want to explain to you why it's such a challenge. Now, you understand something. I didn't start out that way. If she had more than 2 teeth on the bottom, I would have been talking. Maybe I wouldn't even involve implant dentistry. But I did. There was 2 solid cuspids that I could keep. So I was thinking removable, because if she was all right on removable in the maxilla, so you hear what I'm saying to you? All these decisions, you've got to work on this, because it's my opinion that even very, very good dentists that listen to me, my colleagues, it's my opinion that most of you undertreat patients. I see it in young dentists all the time. So you will often do this. Am I wrong? You'll fill a tooth that really needs a crown. And then you'll plant the seed and tell the patient, you're really going to need a crown if this doesn't hold up. Do the crown to begin with. Tell them the truth. But it all starts with a full exam, because maybe that crown is just part of another series of work that they need in phase 1. I always try, I'm going to end with this, I always try to phase treatment if it's possible. If you're opening vertical dimension, you can't phase treatment. So I always try, this is what I would do if I was you. It doesn't treat everything, and that's all documented. See if I'm what I say I am. See if we're as good as I say we are. And if you like us, I'm not going anywhere. I got a lot more to say to you guys about this stuff. And I'm going to make some notes. You're going to hear me talk next week about you being a savant when it comes to patients' personalities and how you need to deal with the personalities, because they're all different. The importance of, are they in pain? Sometimes doing what we call the have-tos. Like there's no room not This is not up for bargaining, whether it's scaling a route plane, any other stuff. I hope this helped. It felt good to me. See you next week, guys. Man, we're not even we're just in the 5th month of the year. There's a lot of time to make this the best year you ever had. See you next week on the Lionhearted.